Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. This is Rebecca Jane Collins. Willkommen auf dem Kanal für Anästhesie und Perioperative Medicine. Merci de nous avoir rejoints aujourd'hui sur la chaîne Anesthésie et Médecine Périopératoire. Today, we're going to dive deep into what is arguably the most fundamental skill in our practice, advanced airway management. But we're not just going to look at it as a single procedure. Instead, we'll treat it as a complete clinical journey, from that very first assessment all the way through to those critical moments after the endotracheal tube has been removed. Our goal here is to blend those core foundational principles with some of the most cutting-edge strategies to really enhance perioperative safety at every single stage.
Right, let's start with a number. A number that I think should make every single one of us stop and think: 18%. It's quite a stark figure, isn't it? And it probably doesn't represent what you might initially assume. This isn't about the challenge of getting the tube in. Oh no, it's about something far more insidious, something that happens when we think the most difficult part of our job is already done.
And here it is. This is the crucial context for that number. According to the ASA Closed Claims Database, a full 18% of the most severe airway complications, and let's be clear, we're talking about death and permanent brain injury, occur during or immediately after extubation. Now, that single statistic should fundamentally reframe our entire perspective. It tells us that our intense focus on securing the airway at the beginning, while absolutely vital, is really only half the story. The end of the journey is just as perilous, if not more so, and that's going to be the central theme of our explainer today.
So here's our game plan. First, we're going to rethink the entire airway journey, pushing ourselves to look beyond just placing the tube. Then we'll explore how technology is dramatically shifting our assessments from subjective guesses to objective, hard data. We'll then navigate a genuinely difficult airway using a fascinating case study. After that, we're dedicating a whole section to what I'm calling the critical art of extubation. And finally, we'll look at the ultimate rescue scenarios and some fascinating integrative strategies that can broaden our entire toolkit.
Okay, so let's start by officially expanding our definition of airway management. It is not a single event, it's a process. A successful outcome depends entirely on a strategy that covers the whole perioperative period. And to do that, we have to revisit the fundamentals. Think about it. The upper airway, your nose, pharynx, larynx, is the conduit. But functionally, it's that complex interplay of the tongue, the epiglottis, and the vocal cords that creates our primary challenges. The moment we induce anesthesia, pharyngeal muscle tone vanishes and the tongue falls back, obstructing the airway. It's why our most basic maneuvers, the head tilt chin lift or the jaw thrust, are so critical. They're the first step in aligning those oral, pharyngeal, and laryngeal axes to create a clear passage for air. When those aren't enough, we escalate to oropharyngeal or nasopharyngeal airways to physically stent that space open. And of course, the foundation of all non-invasive support is effective bag mask ventilation. It's a true skill, isn't it? It requires perfect patient positioning, an absolutely flawless seal, and coordinated ventilation. Every single step requires planning, foresight, and a deep respect for the complications that can pop up at any moment.
And this quote from some very recent literature really captures this paradigm shift perfectly. I'll read it because it's so spot on. A well-planned strategy for tracheal extubation is as important as for the intubation and is correctly regarded as a logical extension of an intubation strategy. You see, this frames extubation not as an afterthought, not as the job's done moment, but as the logical, planned conclusion of our initial strategy. If we treat it with any less rigor, we're ignoring the data, and frankly, we're doing a disservice to our patients. Our plan must have a beginning, a middle, and a very, very well thought out end.
Right, with that holistic view now firmly in our minds, let's move on to our first big action point, assessment. For decades, we've relied on our bedside physical exams, haven't we? But as our understanding of airway anatomy deepens, so too does our technology. We're now in an era where we can finally move beyond those subjective impressions and towards objective, real-time data to predict and plan for difficulty. This slide really illustrates that evolution of our assessment tools. On the left, you've got our traditional methods, the Mallampati score, thyromental distance, interincisor gap. They're foundational, of course, but study after study has shown they have pretty poor sensitivity and specificity. They often miss difficult airways, or, just as frustratingly, flag easy ones. But on the right, you have point-of-care ultrasound, or POCUS. Now this is a proper game changer. It gives us objective real-time data on the patient's actual individual anatomy. And this is particularly powerful in certain populations, like our obese patients, where all those external landmarks can be profoundly misleading.
So let's get specific. What exactly are we looking for with that ultrasound probe? Well, research has identified some key quantitative metrics that are far more predictive than our old exams. For instance, A skin-to-epiglottis distance over about 2.75 centimeters tells us there's a significant amount of preepiglottic soft tissue that's going to get in our way during laryngoscopy. Similarly, a hyomental distance ratio under 1.2 suggests there's just not enough space in that submandibular region to displace the tongue. This objective data then feeds into more sophisticated risk models, especially for tricky things like mediastinal masses. The Erdos and Teneva classifications, for example, use CT findings of tracheocompression to categorize risk as safe, uncertain, or unsafe. Ultrasound beautifully complements this by giving us a real-time, dynamic assessment of airway patency right at the bedside. And beyond just prediction, ultrasound is a procedural powerhouse. We can confirm ETT placement with nearly 99% sensitivity. And in that dreaded SICO scenario, it can guide a scalpel for an emergent cricothyrotomy with a success rate approaching 100%, a massive improvement over the 50%-ish success rate of landmark techniques in difficult necks.
All right, now let's see how all these principles of proactive planning and technology really come together in a real-world high-stakes scenario. This case study involves a patient with a giant mediastinal mass, truly one of the greatest challenges to both respiratory and cardiovascular stability we can face. This isn't just about technique. This is about interdisciplinary strategy, combining that advanced assessment with a preemptive rescue plan from the very start.
So here's our patient, a 78-year-old gentleman presenting with exertional dyspnea and stridor. And as you can see from this table, every single piece of data was pointing towards a catastrophic risk. The clinical signs were classic for severe compromise, but the CT scan, well, it was staggering. His trachea was compressed down to a mere 3 millimeters in diameter. That's a subtotal obstruction. Using the Erdos classification, he was definitively categorized as unsafe, which means there was an extremely high risk of complete airway collapse the moment we induced anesthesia. And to compound all of this, the mass was also compressing the great vessels, producing signs of superior vena cava syndrome. This was a dual threat. Total airway loss and cardiovascular collapse were both very much on the table.
Faced with this nightmare scenario, the team had to plan for the potential failure of the airway altogether, and their strategy was an absolute masterclass in proactive risk mitigation. Step 1 was the most crucial: interdisciplinary planning with anesthesia, thoracic, and cardiac surgery all in the room. Step 2, they performed awake regional anesthesia to facilitate the ECMO cannulation without causing the patient any distress or respiratory compromise. This is clever stuff. It involved a superficial cervical plexus block to anesthetize the skin over the neck for the internal jugular access, and a fascia iliaca block for the femoral vein access site. This meticulous regional technique is absolutely key to keeping the patient comfortable and cooperative. And only after they'd performed Step 3, establishing veno-venous ECMO while the patient was still awake and breathing spontaneously, only then did they proceed to Step 4, a safe anesthetic induction. Finally, with that ECMO safety net securely in place, they performed intubation, using both video laryngoscopy and bronchoscopic guidance to carefully navigate past that tiny 3mm stenosis.
In here again, technology played just a pivotal role. Despite that massive external compression, the video laryngoscope provided a perfect Cormac-Lehane Grade 1 view of the glottis. It just goes to show how modern tools can transform what would have been a blind, high-risk attempt into a controlled, visualized procedure. Video laryngoscopy, whether you're using a hyperangulated or a standard geometry blade, offers a huge advantage over direct laryngoscopy in so many difficult airways. And of course, it's often supplemented by other tools like a bougie or a stylet to help direct that endotracheal tube around an anterior larynx or some other anatomical barrier. It was the combination of a proactive physiological strategy, the ECMO, and this advanced visualization technology that made this seemingly impossible case manageable and, most importantly, safe.
Now, the patient in our case study did well, and he did well precisely because of that meticulous end-to-end planning. And that very same level of planning must extend to the final phase of airway management. As we established right at the beginning, successfully placing the tube is not the end of the story. So now we turn our attention to the most neglected phase, extubation. This is the final and, as the data clearly shows, often the most perilous hurdle. A well-thought-out extubation strategy isn't optional, it is the hallmark of an expert practitioner.
Let's break down the usual suspects when it comes to post-extubation airway obstruction. This table outlines the 4 big ones. First up, laryngospism, that reflexive, forceful closure of the vocal cords that needs immediate positive pressure. Next, laryngeal edema, caused by inflammation from trauma, prolonged intubation, or even anaphylaxis. This needs prompt pharmacological intervention with steroids or nebulized epinephrine. A cuff leak test before you even think about extubating is a crucial predictor here. Third is vocal cord paralysis, a devastating nerve injury, particularly after neck or thoracic surgery that might necessitate immediate reintubation if it's bilateral and severe. And finally, perhaps the most preventable culprit, residual neuromuscular blockade. Incomplete reversal is a major contributor to complications, leading to muscle weakness, impaired swallowing, and respiratory failure. It demands full support and appropriate reversal until objective measures like a train-to-4 ratio greater than 0.9 confirm that muscle function is properly back.
Since laryngospasm is such a dynamic and frankly frightening event, let's focus on a key rescue technique. Larson's maneuver is a really elegant, non-pharmacological method to break a spasm. The technique involves applying firm, often quite painful, pressure to what's called the laryngospasm notch. You can find it just anterior to the mastoid process. This pressure is thought to stimulate nerve pathways that break that reflexive glottic closure, and it often allows you to resume positive pressure ventilation and reoxygenate your patient. It's an absolutely critical skill, but it's just one part of managing postoperative complications. We also have to be vigilant for things like airway trauma, dental injury, and those adverse hemodynamic responses, all of which require their own specific management strategies. So, we've covered proactive planning, advanced technology, and the perils of extubation. For our final section, we're going to expand our toolkit even further. We'll move from managing specific complications to looking at both the ultimate emergency protocol for when everything has gone wrong, and then some integrative strategies that can help optimize airway function across a whole range of clinical contexts.
The SICO scenario, it's the ultimate airway emergency. And the key to managing it successfully isn't some magical new device. It's a calm, clear, and rapid protocol. Step 1 is immediate. Declare the emergency. You need to say the words out loud, cannot intubate, cannot oxygenate, to bring all available help and the difficult airway cart to your side. This is your primary plan failing. Step 2, your secondary plan, is one final brief attempt at rescue oxygenation with a supraglottic airway or a good two-person bag mask technique. If that fails, there is no step 3 other than this: initiate front-of-neck access. This is your rescue plan. You must proceed immediately to a surgical airway. The single biggest cause of poor outcomes in SICO is delaying the decision to cut the neck. And remember, in the pre-hospital setting, with a trauma patient, the pathophysiology might involve mechanical obstruction or even essential apnea from a brain injury. Here, the immediate priority is simply opening the airway, often using a lateral trauma position to allow blood and debris to drain before any other intervention is even attempted.
And to round out our toolkit, it's quite useful to place these acute maneuvers in a broader physiological context. This table compares several different techniques. We've already discussed the Larson maneuver for laryngospasm and the Burt maneuver, that's backward, upward, rightward pressure, for improving your laryngoscopy view. We also have systemic approaches like prone positioning, which dramatically improves VQ matching in ARDS. And just to broaden our perspective further, consider a technique like the suboccipital release from osteopathic medicine. Now, this is grounded in concepts like the primary respiratory mechanism and the cranial rhythmic impulse. The idea behind this gentle technique is to influence fascial tension at the base of the skull, and in doing so, modulate vagal tone. Now, while it's certainly not an emergency maneuver, its goal highlights a different dimension of airway management, optimizing the underlying physiology that governs airway function, which can be a really valuable adjunct in conditions like asthma or pneumonia. This integrative view really completes our strategic toolkit.
So, we end where we began, but hopefully with a much broader perspective. We have incredible technology at our fingertips: video laryngoscopies, ultrasound, ECMO. But as this explainer has shown, the true leap forward in airway safety might not come from the next new device. Instead, the next frontier lies in our intellectual and our collaborative capacity to see airway management not as a procedure, but as a complete patient journey. This means using safety checklists for every high-risk phase, a checklist for assessing the patient with an airway tumor, a checklist for extubation readiness, and a checklist for the initial assessment of the trauma patient. It's about proactive planning, interdisciplinary strategy, and respecting every single phase of the process, especially the end. Thank you for watching.